All right, so let's talk about chest tubes quickly. Why do we place chest tubes? Well, they're right there in the middle of the screen. However, if we look at the chest x-ray on the left, you'll see that there's a nice large air pneumothorax. This is going to be a tension pneumothorax, not just simple, because you see the shift of the mediastinum. Second, you can have large effusions, hemothorax, or empyema, which are evidenced here. Please note that you don't see a nice clear edge of the lung anywhere. You see where the liver should be, just turning straight into an area of where you think lung may be. So since it's the same density, there's no difference. Since there's no difference, that's how you know there's fluid there, as opposed to a pneumonia. Sometimes with just flat out pneumonia and no fluid, you may still see this picture, but this typically indicates fluid. Sometimes you can also see a meniscus, but we don't see that evidenced here. So when you have either one of these two patients, you're going to put a chest tube in. There's a bunch of different types of chest tubes. In the top one where you see chest tube, it says large bore, large side ports, which are very good for fluid. An empyema can be very thick, blood can be thick, and fluid can have fibrin products that will block up holes. So you want something with long, or rather big, holes. In the lower one there, you see the pigtail catheter. It has several small ports. It's great for air, which can get easily clogged if there's blood or other fluid. So you can use it for fluid, especially in smaller children because it's a small caliber to fit through their ribs, but it's not the best. Finally, in the third picture, where you see the placement of the tubes, for air, you really want to angle them towards the apex of the lung, anterior apex of the lung, because that's where the air is going to rise to. Whereas fluid, you want it to the most dependent area of the lung, which is usually posterior and low, inferior. All right, so then you got to hook the chest tubes up to something, and this is what you're going to be checking every single day. The collection chamber. So this is one type of a collection chamber called a Pleurovac. It's different than the three-chambered one where you have fluid for the suction control. In this one, you'll see the suction control is that red knob on the top left. Looking here, the suction control is circled or squared with a yellow outline. You'll see next to that is an orange box. That tells us if the suction is on or off. Currently, you see that it is off. The green box highlights the area of water seal. This is where you'd look for bubbles if there is a persistent air leak or pneumothorax. Outlined in blue is the fluid collection chamber, and that's where you'll have your pleural fluid or blood draining out. Here you see what the orange box looks like. It will be filled with an orange accordion-like material so that you know the suction is on. All right, moving on. I don't know why I have another blank slide here. Moving on. So this is what it looks like as it starts to fill up. Blood will go into the chamber and you see the orange box on. And that's what you're looking for every day when you come in. The other thing that you're going to be looking for is any bubbles flowing through the blue fluid of the suction of the water seal. I'd like to show you another type of chest tube collection container, which may also be commonly used in the hospital that you're working at. If you see here in the picture on the left, outlined in yellow, again, is the suction control. However, in this one, it is done by water. A certain amount of water needs to be added to create 10 centimeters of water or 15 or 20 centimeters of water negative pressure. Outlined again in green, which is difficult to see in the picture on the left, is the water seal chamber, which again you would look for bubbles the same exact way. Outlined in blue is the collection chamber once again. You can follow the tubes to see how this one actually gets hooked up. In the drawing on the right, you again see the flow of chest tube fluid or pleural fluid going down into the collection chamber, and the yellow, which is air, flowing down through the water seal, then out through the suction. And you can see how the suction works to then be able to create negative pressure, or rather a controlled negative pressure. All right, so this is a patient with chest tubes in. How many do you see? Perfect. Right, 3. 1, 2, and 3. Now, look at the one on the inferior aspect of the right lung. Is it broken there? Do you see that? You see that break in the white line there? But do you know what that white line is called? Yeah, we call it the radio-opaque line because it's opaque on radiography. But what? Is it broken? Right there. You see what I'm talking about? Right there. Is it broken? What? And then look closer and, oh, dude, we put 3 defective chest tubes in? Is that what happened? No. We call that the most proximal hole. So proximal on the tube to that, there are no other holes. So you have the hole there and then holes all the way to the tip of it. All right. So if I told you this patient who had 3 chest tubes, we go and remove one and they're doing totally fine. And then overnight they start decompensating more and more and more. And they're having a harder time breathing again. And then we get a chest tube in the morning and we see this. What happened? Right, so I've already highlighted the chest wall for you in the yellow, and you can see that the most proximal hole has come out on the left side, on the right side. So you can't just push that back in. You got to take it out, you got to replace it if they need it. All right, so again, is there bubbling? And what do we mean by bubbling? Is it good? Is it bad? What do you think? So when I say is there bubbling, looking at this Pleurovac, I'm saying, is there bubbling going through the blue fluid at the bottom, right? Our water seal. And we mentioned it before, but if there's bubbles going through that blue fluid, we know that there's still an air leak, all right? Now, what do we mean by air leak? That's what we're going to go on and review. So again, the fluid comes in, the air goes through, bubbles on through, and you note that the suction control is on. All right, so when we look at the old style of chest tube, right, you can have just a simple seal, then you can have water seal, and then you can have water seal with suction control, right? So we're not talking about those two. We're just talking about the 3-bottle system, which is demonstrated in both collection chambers that we showed you. So what we're primarily talking about when we are worried about bubbles coming through the water seal is this area, all right? So 1, there may just be a persistent pneumothorax in the patient. Okay. 2, the most proximal hole may have migrated out of the patient just a little bit, and that's where air is coming from. 3, there could be a hole or a break in the system anywhere that's highlighted pink within that blue dotted line. If there is a hole or a break, there will be air coming through the water seal. So your job is to go back and check all the tubing. It's unlikely that your Pleurovac system will have a crack in it. Is it possible? Maybe. But you have to inspect the entire tubing, inspect the tube, get a chest x-ray, and figure out if it's coming from the patient or from one of our devices. Finally, we just need to talk a little bit about complications. So the air leak and migration of the tube and dislodgement of the tube, meaning it could come out all the way. Now, it could also migrate in, and migrating in could be a very bad thing. You can also have the tube clotted. The tube can obstruct, like an empyema or with fibrin clots, or you can get infections, and those are all common things. Also, you may wind up getting pain, and so if you have a lot of pain from the chest tube, you don't want to keep giving morphine over and over. Sometimes pain patches, nerve blocks, gabapentin may be a good thing. So instead of trying to figure it out, call the pain team. There can be persistent bleeding depending on how the tube was put in. If the blood may be coming from the pleural space, or maybe an artery or vein was nicked. So you always need to inspect the chest wall site for any bleeding, meaning the gauze, not so much taking the bandage off. Please do not take the bandage off. They can cause arrhythmias, especially if they're on the left side, because they can be touching the heart. If that's the case, you need to call surgery and make sure it gets adjusted. They can actually, in the process of putting the chest tube in, puncture or injure the ventricle of the heart. That's bad. You probably won't need to deal with that. However, it is a complication that can occur. Nerve damage can occur along the costal margins because of where the tube was put in, and if you have too much pressure because of a very large tube on a nerve, you can wind up having some damage. And there's plenty of other things that can happen, but these are the main ones that you need to know about while you're caring for your patients.